Schizophrenia and Mood Disorder. Schizophrenia. 1.1 Clinical manifestations of schizophrenia. Schizophrenia is a chronic and severe mental disorder that affects how a person thinks, feels, and behaves. The symptoms are typically categorized as positive symptoms, negative symptoms, and cognitive/disorganized symptoms. 1. Hallucinations. These are false sensory perceptions that occur without any external stimulus. The most common type in schizophrenia is auditory hallucinations, where the person hears voices that others do not hear. Visual, tactile, olfactory, or gustatory hallucinations may also occur. 2. Delusions. Delusions are fixed, false beliefs that are not based in reality and are not influenced by logical reasoning. A delusion of control. The person believes that their thoughts, feelings, or actions are being controlled by external forces, e.g., someone is controlling my limbs. B. A paranoid delusion. Also called persecutory delusion, where the person believes that others are plotting against them or trying to harm them, e.g., people are watching me through cameras. C. Grandiose delusion. The individual believes they possess extraordinary powers, talent, or importance, despite evidence to the contrary, e.g., I am a famous scientist chosen by God. D. Somatic delusion. Involves false beliefs about bodily functions or physical condition, e.g., my stomach has turned into stone. 3. Disorganized thinking. Also referred to as formal thought disorder, this includes incoherent speech, word salad, loose associations, tangential thinking, difficulty organizing thoughts. 4. Abnormal motor behavior. This may include agitation or unpredictable movements, catatonia, lack of movement or response to the environment, repetitive or purposeless activity. 5. Negative symptoms. These reflect diminished emotional expression and a lack of normal functioning, including affective flattening, reduced emotional expression, avolition, lack of motivation, alogia, reduced speech output, anhedonia, inability to feel pleasure, social withdrawal. 1.2 Epidemiology of schizophrenia. Global prevalence affects approximately 1% of the global population. Age of onset typically emerges between late adolescence and early adulthood, 15 to 35 years. Gender, slightly more common in males, and males tend to show earlier onset and more severe symptoms. Course, it can be chronic and relapsing, though some individuals experience periods of remission. 1.3 Etiology of schizophrenia. Schizophrenia has a multifactorial origin, involving biological, genetic, psychological, and environmental factors. 1. Genetic factors. A strong hereditary component. Risk increases if a first-degree relative, e.g., parent or sibling, has schizophrenia. Concordance rates are higher in identical twins, 40 to 50%, than in fraternal twins, 10 to 15%. 2. Environmental factors. Prenatal stress or malnutrition. Complications during birth. Urban upbringing, poverty, and childhood trauma. Substance abuse, especially cannabis, is linked to increased risk. 3. Neurotransmitter imbalance. The dopamine hypothesis suggests that excessive dopamine activity in certain brain areas contributes to psychotic symptoms. Other neurotransmitters such as glutamate and serotonin may also be involved. 4. Brain anatomy. Imaging studies reveal structural abnormalities. Enlarged ventricles. Reduced gray matter volume. Abnormalities in the prefrontal cortex and hippocampus. These changes are associated with cognitive and emotional deficits. 1.4 Management of schizophrenia. Effective treatment usually involves a combination of medication, therapy, and social support. 1. Pharmacological treatment. Antipsychotic medications are the primary treatment. First generation, typical e.g., haloperidol, chlorpromazine. Second generation, atypical e.g., risperidone, olanzapine, clozapine. Atypical antipsychotics are preferred due to fewer side effects. Medication helps manage symptoms but does not cure the disorder. 2. Psychosocial treatment. Cognitive behavioral therapy, CBT, to manage delusions and hallucinations. Family therapy reduces relapse by improving family communication and support. Social skills training, to improve interpersonal and occupational functioning. Supported employment and education, to reintegrate patients into society. 3. Hospitalization. Required during acute episodes, severe psychosis, or when the patient poses a risk to self or others. Inpatient care provides a safe and structured environment for stabilization and beginning treatment. After stabilization, community-based care and follow-up are essential. Cloud with rain mood disorder. Small blue diamond definition of mood disorder. Mood disorders, also called affective disorders, are a category of mental health conditions that primarily involve disturbances in a person's emotional state. These disturbances may be in the form of prolonged periods of sadness, depression, or episodes of extreme mood elevation, mania or hypomania. These disorders significantly impair the individual's ability to function in daily life. Small blue diamond 1.1 Clinical manifestations of mood disorder. Mood disorders are broadly classified into two major categories. 1. Depressive disorders. These are characterized by persistent low mood and loss of interest or pleasure. Common clinical features include persistent sadness or emptiness, fatigue and low energy, loss of interest in previously enjoyable activities, changes in appetite or weight, sleep disturbances, insomnia or hypersomnia, difficulty concentrating or making decisions, feelings of worthlessness or guilt, thoughts of death or suicide. Subtypes include major depressive disorder, MDD, persistent depressive disorder, dysthymia, Postpartum depression. Seasonal affective disorder, SAD. 2. Bipolar and related disorders. These involve alternating periods of depression and elevated mood, mania or hypomania. Manic episode features: elevated or irritable mood, inflated self-esteem or grandiosity, decreased need for sleep, increased talkativeness, racing thoughts, risk-taking or impulsive behavior, distractibility. Types include bipolar I disorder, at least one manic episode, possibly with depressive episodes. Bipolar II disorder, hypomania and at least one major depressive episode. Cyclothymic disorder, milder, chronic mood fluctuations. Small blue diamond 1.2 Epidemiology of mood disorders. Mood disorders are among the most common psychiatric illnesses. Depression affects more than 280 million people worldwide, WHO, 2023. Bipolar disorder affects around 1 to 2% of the global population. Age of onset, late adolescence to early adulthood. Gender, depression is more common in females, while bipolar disorder affects both genders equally. Suicide risk is significantly higher in mood disorders, especially during depressive and mixed episodes. Small blue diamond 1.3 Etiology of mood disorders. Mood disorders have a multifactorial origin, involving genetic, biological, psychological, and environmental factors. 1. Genetic factors. Family and twin studies suggest a hereditary component. Risk is higher in individuals with first-degree relatives suffering from depression or bipolar disorder. Heritability estimates. Major depression, 40%. Bipolar disorder, 70-80%. 2. Biological factors. Neurochemical imbalances, especially in serotonin, norepinephrine, dopamine, are linked to depression and mania. Hormonal changes, such as those in thyroid dysfunction or postpartum period, can trigger mood disturbances. Brain structure abnormalities. Reduced volume in prefrontal cortex and hippocampus in depression. Hyperactivity in amygdala during depressive episodes. 3. Environmental factors. Stressful life events, e.g. trauma, loss of loved one, unemployment, childhood abuse or neglect, poor social support, substance abuse and chronic illnesses. These factors interact with biological vulnerabilities to trigger or worsen symptoms. Small blue diamond 1.4 Management of mood disorders. Effective treatment requires a multimodal approach, including medication, therapy, education, and social support. 1. Pharmacological treatment. Antidepressants. SSRIs, e.g., fluoxetine, sertraline. SNRIs, TCAs, MAOIs. Mood stabilizers. Lithium, valproate, carbamazepine. Antipsychotics, used in bipolar disorder, e.g., olanzapine, risperidone. Medication choice depends on diagnosis, symptom severity, and comorbidities. 2. Psychosocial treatment. Cognitive behavioral therapy, CBT, to address negative thinking patterns. Interpersonal therapy, IPT, improves relationships and communication. Family-focused therapy, enhances support system. Group therapy, reduces isolation and builds coping strategies. 3. Psychoeducation. Educates patients and families about nature of illness, early warning signs, medication adherence, relapse prevention. 4. Counseling to patients and families. Focus on emotional support, validation, and problem solving. Helps manage stress, conflicts, and life transitions. 5. Supportive therapies. Lifestyle modifications, exercise, diet, sleep hygiene. Encouragement of social engagement and routine. Vocational rehabilitation and self-help groups.
Thank you so much for watching. Don't forget to like, share, and subscribe. See you in next video.